Good morning. I'll be speaking on branch retinal vein occlusion. Retinal vein occlusions, as we already know, are the most common cause of retinal vascular disease after diabetic retinopathy. BRVO is 3 times more common than CRVO, occurs at the AV crossing where the artery and the vein share a common adventitial sheath, and is common in patients from 60 to 70 years of age. The prevalence seen in many major studies has varied from between 0.6% to 1.3%. Males and females are equally affected. There's no racial predilection. There's no definite association with diabetes or open-angle glaucoma. And the superiotemporal vein is the area which is most commonly affected. Systemic risk factors include systemic hypertension, a risk of cardiovascular disease, hyperlipidemia, and hypercoagulable states. Other factors like blood dyscrasias, vasculitis, and autoimmune disorders like SLE also may be a cause. The eye disease case control study found that the risk of BRVO increased with systemic hypertension, cardiovascular disease, and a high BMI, whereas it decreased with higher risk of alcohol consumption, which I don't think we should take with a pinch of salt, and also with high disease lipoprotein cholesterol. So, why does a patient come to us in BRVO? Basically, it's because of the vision limiting complications, most important being macular edema, followed by macular non-perfusion, vitreous hemorrhage from neovascularization, traction retinal detachment, and neovascular glaucoma. Who do we work up? All patients who have a retinal vein occlusion should have a comprehensive ophthalmic evaluation, including an appropriate evaluation for glaucoma. Patients, however, who are more than 60 years old, who have a known systemic vascular risk, do not need a systemic workup. This is important so that we don't over-investigate our patients. However, keep in mind that young patients or those with bilateral simultaneous vascular occlusions need a thorough evaluation for any hypercoagulable condition so that the risk of future non-ocular thrombotic events can be cut in the bud or nipped in the bud at that point only. Standard tests include a complete blood count, including ESR, liver and kidney function tests, a glucose test, lipid profile, and urine analysis. And it's nice if we refer our patients to their primary care physician for an evaluation of the cardiovascular risk factors. A thrombophilic screen is very important in the younger patients, which include the coagulation profile, homocysteine level, antiphospholipid antibodies, protein CNS, and anti-nuclear antibodies. There's a whole long list of ophthalmic investigations to be done, but the most important are angiography and the OCT. The angiography in the acute phase will show superficial hemorrhages, retinal edema, delayed AV time, venous dilatation and staining of the vessel walls, macular edema, and if there's capillary non-perfusion, we might have macular ischemia. The angiography also helps to differentiate the collaterals from the neovascularization. OCT, Dr. Abhishek has already discussed the findings. This is a study we did some time ago, and we found the most common pattern in the natural history of BRVO was a combined pattern in which there was a serous retinal detachment along with cystoid macular edema, and this was seen in 45 patients of all BRVO. And prior to this, in the pre-OCT era, it was not even known that serous retinal detachment was so common in patients of vascular occlusions. So only after the OCT have we been able to diagnose the serous retinal detachment. General management principles for any disorder actually should be to maximize the recovery and the vision. We must also detect any systemic disease, detect and prevent glaucoma, and protect the other eye. So the management, the ways we can manage it, firstly by observation, second laser photocoagulation, or we can have intravitreal or Steenlen's triamcinolone. The intravitreal anti-VEGFs are a new weapon in our armamentarium, or a combination therapy of these, which we'll also discuss, and the new Ozurdex implant. So just to show you a few cases, because we try to make it more practical. This is a 30-year-old man with some hemorrhages in the superior temporal quadrant, and the vision is 6/6, but he is disturbed by a shadow. And we just observed this patient, and you can see the edema has gone decreased a lot spontaneously, and the patient feels much better. So in this position, I think observation may have been the right decision. What about the role of laser? The BVOS says to wait for 3 to 6 months for the hemorrhages to clear, and if the vision is less than 6/12, we should repeat a good quality fluorescent angiography. In case of perfuse macular edema, we should do a grid laser, and in case of non-perfusion, we need to just observe the patient. That was the condition of the BVOS. And they said this because 63% of the treated patients gained more than 2 lines compared to 36% in which the grid laser was not performed. What is the role of peripheral scatter lesion? According to the BVOS, 22% of the controls versus 12% of the treated developed neovascular complications in BRVO. And it was found with patients with extreme, Dr. Abhishek has already told us, in CRVO it was more than 10 disc diameters, but in BRVO more than 5 disc diameters was considered to be ischemic. And they were considered ischemic, and out of them 40% developed neovascularization. And when they accumulated all the data, they postulated that peripheral scatter should only be done after the development of neovascularization. So this is the standard of care as of now. IVT also has a role. It's indicated in the to reduce the macular edema, especially patients who have a serous detachment, which I said is now being diagnosed with the OCT. And generally the dose is 4 milligrams. But the SCORE trial used the multiple doses including 1 milligram, 2 and 4 milligrams. It helps by stabilization of the blood-retinal barrier, downregulates VEGF. However, complications like glaucoma, cataract, pseudo-endophthalmitis are seen with this. And SCORE study found, in fact, there was no difference in vision acuity at 1 year between the IVTA and the laser groups. But they found more complications with IVTA. So according to the SCORE study, the grid laser remains the standard of care for patients with macular edema in BRVO. Now we come to the anti-VEGF agents. All the 3 anti-VEGF agents have been used in BRVO. There is no standard treatment protocol. All of them show improvement in vision and decrease the macular thickness. There was a large study called the BRAVO study, and the 6-month endpoints, which were published in 2010, showed that monthly injections, the gain of more than 15 letters was seen in 61% of the 0.5 versus 28% in the sham. So this was highly statistically significant. And after they completed 6 months, they further followed the study up for another 6 months. This is a BRAVO study published in 2011 in ophthalmology, and they found that the benefits were extended, and there was excellent safety profile for this. But unfortunately, this leads to a massive cost factor, and because multiple injections are needed to maintain this decrease in the thickness and the visual gain, and the effect, as already told, lasts for around 6 weeks. So normally the patient, the most common treatment protocol is to give 2 or 3 injections over the first 5 to 6 months, and then we do it in a PRN manner. Rebound edema, this is something which has been noted recently, that there may be rebound macular edema following anti-VEGF therapy for venous occlusion, and this is more pronounced after treatment. And it has been postulated by Matsumoto et al. In the Retina Journal that the inhibition of the VEGF pathway leads to upregulation of the VEGF receptors, and the increase in the VEGF receptors makes the endothelial cells more sensitive to the VEGF already upregulated because of the underlying ischemic state. And this is one patient in which we find the edema in fact increasing because of rebound phenomena, and you can see macular thickness is maximum at the last visit. So in light of this, I would like to throw up a question: is there a need to change the laser guidelines in the era of the anti-VEGF therapy? And because the upregulation of VEGF receptors is seeming to lead to more of the edema and neovascularization. And another very important thing is that the guidelines regarding the ischemic factor, because the ultra-wide angiography, which already has been shown, it has been shown by this that peripheral untreated capillary non-perfusion areas anterior to the equator and has been significantly found to be associated with macular edema at the posterior pole. So the role of ultra-wide wide field angiography is also coming into question nowadays when we treat the vascular occlusions. So to obviate some of these problems, we did a series of a small series of patients where we combined intravitreal bevacizumab along with intravitreal triamcinolone for macular edema secondary to BRVO, and we gave a combination therapy and assessed for the side effects, change in vision and the macular thickness. And we had very encouraging results. We found the thickness decreased from around 550 micron to 268, and you can see the graph, and at last follow-up also the thickness decreased. And the number of injections only 1.24 per patient, and the vision increased from approximately 20 by 100 to 20 by 40 at 1 month, and it improved further to 20 by 33 at the last visit. 3 patients had a higher IOP than 21, and they were topically controlled with medication. This is just one representative case, and you can see the edema is decreased after single combination therapy. Another patient where we see the OCT, you can see there's a serious detachment along with cystoid macular edema, and a relatively normal scan, and a restored foveal contour after the combination therapy. So what about certain clinical situations? Like this is a 69-year-old lady with 6/9 vision, and we can see hard exudates and some hemorrhages. And now when we see the angiography, we see there's large areas of capillary non-perfusion in the periphery, but no definite neovascularization, and a lot of thickening on the OCT. So options for this patient are IVTA, IVA combination, plus minus laser. You know, it's a confusing scenario now because we have so many options. So we gave the patient a combination therapy, and we did follow it up with scatter laser to the capillary non-perfusion areas, and she's stable at 4-month follow-up. But still, there are patients who are great challenges to us. Now, this is a 68-year-old gentleman, known hypertensive and diabetic with a superior temporal vascular occlusion. He has received 2 combination injections and 4 Avastins over past 11 months. And at the last follow-up, he has shown recurrence of edema. So the patient is not happy, and these are real challenges to us now. So for some of these challenges, a new therapy has been introduced, the Ozurdex, and this is a biodegradable implant which is supposed to help us reduce the number of retreatments we have to give, because it is said that the effect is up to about 6 months. Practically, we are going to ascertain exactly how long this stays in our patients. And this was the Ozurdex Geneva study. And when they found the time to achieve more than 15 letters gain in the visual acuity, they found that it was less in the implanted group compared to sham. And again, the BCVA improvement was also statistically significantly greater in the dexamethasone group. And the pressure more than 25 was noted in 16%, and it's important to know in this case it peaked at the 2nd month. So if we do inject Ozurdex, we must keep a close watch on pressure, and not just initial month, but even up to the full duration till we can see the implant in situ. And this is just one of our patients who's a 72-year-old male who had a BRVO. He had a recent stroke, and this is one of the indications where we give pegaptinib instead of the other anti-VEGF agents. And in spite of that, he had recurrent edema, so we gave Ozurdex. At 3 months follow-up, his OCT is stable, vision is stable, and we have to see what happens. Other modalities, I will not go into details. Dr. Abhishek has covered all these modalities very well. I'd just like to say thank you.